And good afternoon again, everybody. So we may have people continuing to enter the webinar space over the next few minutes, but I'd like to welcome everybody to today's Arizona Center for Rural Health, Arizona State Office of Rural Health webinar series. And my name is Jennifer Peters. I work here at the Arizona Center for Rural Health. And we have this webinar series once a month to disseminate research findings, policy updates, best practices, and other rural health issues. And we thank you for joining us today. Next slide, please. So our webinar series is made possible with the support of our partners in the Arizona Telemedicine Program and the Southwest Telehealth Resource Center. Next slide. A few webinar tips and notes for today's presentation. The audience will be muted, but you will have access to the chat box, and we encourage you to please enter your questions in the chat box. There will be a post-webinar survey. We encourage you to please complete that survey, as it gives us important feedback about this webinar series as well as ideas for upcoming topics. And the recording will be posted on our Center for Rural Health website and the website of the Southwest Telehealth Resource Center. And the recording will include a copy of the slide presentations. Next slide. So once again, we hope you have lots of questions. We're leaving time for discussion. And use the chat box to enter those, and another reminder about our survey. And with that, I think we'll get started with today's presentation.
Excellent. Thank you, Jen. Hi, everybody, and good afternoon. My name is Brenna Koch, and I'm here with my co-presenter today, Ben, and we'll introduce ourselves a little more in just a minute. But the presentation that we are providing today is an overview of the behavioral health care workforce and access to medication for opioid use disorder treatment in rural Arizona. So a little bit more about me. As I said, my name is Brenna Koch. I work here at the Arizona Center for Rural Health since 2016. My main focus at the Center for Rural Health is assisting with data collection, management, and analysis and reporting, particularly with reference to the healthcare workforce in Arizona. I'm also a doctoral student here at the College of Public Health, and my main research interest is the impact of policies like the Affordable Care Act on health outcomes for underserved and vulnerable populations. And then I'll let my co-presenter Ben introduce himself.
Thanks, Brenna. Yeah, so I'm the picture below Brenna, the floating head in the red shirt. Like Brenna, I also studied at the University of Arizona. I got a little bit of a head start on her because I got through the finish gate a couple of years ago. I'm currently an assistant research professor. My background was research on nicotine and tobacco and cessation treatment. And for the last 2 years, I've worked with Brenna at the Center for Rural Health on workforce questions and in the space of opioid use disorder on workforce development. Thank you all for joining us.
Excellent. Thanks, Ben. So the Arizona Center for Rural Health, just a little reorientation. Our mission here is to improve the health and wellness of rural and vulnerable populations. And in the slide set that you'll receive, we do have a link to our latest annual report about what the Center for Rural Health has been up to this past year. We'll go through the learning objectives for today. So first, we're going to describe behavioral health needs in rural Arizona. We'll describe the distribution of the behavioral health care workforce and shortages of the workforce in rural Arizona. We'll also describe the current context and need for access to medication for opioid use disorder and treatment in rural Arizona. And we'll identify opportunities for improving access to behavioral health care and to medication for opioid use disorder treatment. We're going to be referencing a lot of research data and other information from 2 reports And I think we'll be able to put the links to these reports in the chat for you as well. So the first is an overview of the Arizona Behavioral Health Workforce, which is posted on our Center for Rural Health website. And the second report is research that was recently published about expanding access to medication for opioid use disorder treatment. And so we'll put those links in the chat for you so you have access to those resources. We are going to use some acronyms today, so I just wanted to highlight those for you quickly on this page. So I'm not going to go through them all, but here are the acronyms you might hear us use. We'll try our best to define them the first, or say what they are the first time we use them. But if we do miss them, please feel free to ask us in the chat or refer to this slide. So part one, the need for services. So some quick context setting. We're going to use the word behavioral health in this presentation. And for us, that includes mental health, substance use disorders, and co-occurring disorders, which are the presence of both mental health and substance use disorders. We want to recognize that mental health and substance use disorders affect people from all walks of life and all age groups. These illnesses are common, recurrent, and they can be serious, but they are treatable. And many people do recover or have cycles of recovery throughout their lives. For people experiencing substance use disorders, the way that we're using that term is to refer to when recurrent use of alcohol or drugs causes clinically significant impairment, including health problems, disability, or the inability to meet major responsibilities in work, school, or at home. We also want to make sure that we emphasize, while we are talking about these conditions at the population level, it's also important to think about the individuals and the complexity and diversity of their lives, and that we use words and terms that help to reduce stigma. And so we have some resources on stigma reduction linked at the bottom of this slide. A little bit of a larger context, thinking about upstream and downstream factors and impacts of mental health and substance use disorders. We just wanted to lay this out for you, thinking about the upstream factors like social and economic policies and infrastructure. And then where we're really focused today is kind of in the midstream, so that in terms of health conditions, and then addressing whether or not healthcare to meet those health needs is available where people are, whether or not it's accessible and they can get to it within a reasonable amount of time. The downstream factors, which you're probably all familiar with, of course, are the health conditions related to substance use disorder and things like opioid overdose. A little bit more context on substance use and mental illness in the US. So about 20% of adults in the US report any mental illness in the last year. This is data from 2019. And about a quarter of those individuals perceived an unmet need for mental health services in the past year. And so you can see those two charts that outline the mental health experience, like any mental health illness in the past year, and then the perceived unmet need for mental health services in the prior year. About 24% of adults in the US had either any mental illness or substance use disorder in the prior year. About 9.7 million had a substance use disorder alone. That's represented in the yellow figure, that yellow part of the diagram on the left. About 9.5 million had both any mental illness and a substance use disorder. And about half of those people received substance use treatment at a specialty facility or in the prior year. But you'll see in figure 80 on the right-hand side that the receipt of treatment really has been stable over the last 5 years. In Arizona, our prevalence matches roughly national prevalence for substance use disorder in the past year, about 7%, and any mental illness in the past year at about 18%. Nationally, what we've been seeing in the prior years are increased substance use involved mortality. You see this chart has the 2019 drug-involved overdose deaths at about just over 70,000. And in 2020, this number increased to 93,000 deaths. So this is a 30% increase since 2019. Of fatal overdoses, 70% are linked to opioids, primarily fentanyl. In Arizona, we're observing similar trends with increasing trends of opioid-related deaths. So now that we've provided a brief overview and context of the need in Arizona, we're going to talk a little bit about the workforce distribution and shortages. So when we talk about workforce distribution, really what we're talking about is the ability of folks in Arizona to access the healthcare they need. And this is about the timely use of personal health services to achieve the best health outcomes. That's what we're really talking about when we're talking about access to care. And there are 5 elements of access: affordability, availability, accommodation. Is the care acceptable to the person? Is it culturally relevant and appropriate? And is it accessible? Is it geographically proximal to the individual needing the care? And the workforce really we're focused on right now is availability. Are there workforce professionals? And accessibilities. Are they nearby to the person who needs care? So in terms of geographic proximity, if healthcare is further away, an individual is less likely to receive the care that they need. And this lack of geographic proximity can disproportionately affect low income, low literacy, older, more rural, and under-resourced communities. Traveling distances to seek out care has a cost for individuals and communities, including economic costs, time costs, and social costs. Having to travel for care decreases the likelihood that someone is going to receive timely preventative and primary care. And the Department of Health and Human Services considers any travel over 30 minutes as excessively distant. This is a map of the health professional shortage areas that are specific to mental health professionals. HPSAs are tracked by the Arizona Department of Health Services workforce designation programs. And according to HRSA, so the data gets rolled up from ADHS to the Health Resources and Services Administration, 40% or 2.8 million of Arizona's population lives in a mental health professional shortage area. So currently in Arizona, we're only meeting 11% of our mental health needs compared to 26% nationally. And just a note here for determining the health professional shortage areas for mental health HPSAs, this is based only on the distribution of the psychiatrist workforce in Arizona. And overall, HRSA and ADHS estimate that we need 182 practitioners to remove the designation. And this puts Arizona at the 6th highest number for mental health HPSAs in the US. From the report that we provided the link to, we looked at the distribution of the mental health and behavioral health workforce across Arizona, and we looked at several different types of professionals in this workforce. And so what this table is just a count of these professionals by county. I just want to highlight some of the counties that have very few health professionals. And as we know in Arizona, Arizona has 15 counties. Some of them are very big geographically and have low populations that are spread out. And so these low numbers are concerning for access in these counties. When we look at the ratios of these providers per 100,000, we see, and I'm going to draw your attention to kind of the opposite case where the providers are really clustered in our 2 most populated and the counties that have the most populated metropolitan centers, so Maricopa and Pima County. When we look at the distribution by rurality, we use rural urban commuting area codes, which are sub-county designations of rurality. And they use census tract or zip code level population, density, urbanization, and daily commuting data to categorize rurality. And we group these into 4 categories of urban areas, large rural, small rural, and isolated small rural areas. So just for reference, about 90% of Arizona's population lives in urban areas, 10% are in rural areas, but only 4.3% of the behavioral health workforce is rurally located. So you can see in this chart, we have the population, the percent of the population in Arizona that lives in those areas, and then the related percent of the behavioral health care workforce that are in those areas. So you can see in the rural levels, there's a mismatch between the percent of population that live in those areas and the percent of the workforce that are in those areas. We see somewhat similar trends when we look at the ratio of providers per 100,000 across these areas. There are some interesting differences, but generally we see that the behavioral health providers are clustered in urban areas, and the ratios of providers per population is lower in rural areas. The case where this doesn't seem to be quite as true is for substance abuse counselors in Arizona. All right, that's an overview, background, and overview of the workforce, and I'm going to kick it off to Ben for the next section.
Thanks, Brenna. So for this next section, we wanted to give, I won't call it a case study, we wanted to give kind of a detailed view of what we mean by proximal workforce and what some of the implications are. And so we're going to more narrowly look at opioid use disorder and the workforce that is licensed to prescribe medications for opioid use disorder. So I'll give a couple of background slides again on this topic, and then we'll get into what that looks like in Arizona. So medication for opioid use disorder, or MOUD, is recommended by virtually every national federal level agency that works in this area: American Academy of Addiction Psychiatry, American Medical Association, NIDA, the National Institutes of Drug Abuse, CDC, so on and so on. The point in specifying that, saying that out loud for our audience today, is to say that, yeah, historically, counseling and behavioral health psychosocial services have been really helpful and continue to be extremely helpful for medication for opioid use disorder, or sorry, for treatment for opioid use disorder. But medication has been a more debated and misunderstood aspect or component of care. And so we just wanted to clarify for our audience that we're at the point now with our evidence base that most people who are diagnosed with opioid use disorder should be considered for receiving a medication as a recommended first-line treatment. Not necessarily to replace, but certainly to complement counseling and behavioral health care if and when appropriate. And the three medications that are prescribed for OUD is methadone, buprenorphine, and naltrexone. And we'll talk through in the coming slides kind of some of the policy and licensure differences between being able to access these three different medications. So methadone is a full opioid agonist, which means it fully activates the opioid receptors in the brain, and is classified as a level 2, schedule 2 narcotic within the Drug Enforcement Agency's scheduling of controlled substances. And so under that designation within the United States, it's only allowable to be prescribed and dispensed within licensed clinics. Oftentimes we refer to them as methadone clinics. Their technical name is an opioid treatment program. Going back to '74 is when the first clinics were put in place, and currently there's around 1,700 in the US. In Arizona, 58 where public can access. Buprenorphine is a partial agonist. It partially activates and partially blocks that opioid receptor. But different from methadone, buprenorphine can be prescribed in an office-based setting and dispensed through a pharmacy as a Schedule 3 controlled substance. So the Drug Addiction and Treatment Act of 2000 brought this about. And so starting in 2002, providers are able to apply or submit a notice of intent to the DEA saying that they would like to prescribe buprenorphine for individuals with opioid use disorder. And once that happened, starting in 2002, and then measured over 9 years to 2011, we saw that just the geographic spread, or the geographic accessibility to a provider who could potentially prescribe buprenorphine increased, represented in 27 counties before the Drug and Addiction Treatment Act, all the way up to 76 by 9 years later. 2016, it further changed, where initially only physicians can prescribe. As of 2016, the CARA Act allowed nurse practitioners and physicians' assistants to begin prescribing buprenorphine. And we've seen a further increase in accessibility or geographic proximity to a provider. And in rural areas, that's been really benefited from the advent of nurse practitioners being able to prescribe from primary care settings. That being said, and if we go back to what Brenna was telling us about the multiple layers of access, we're only talking about a workforce that's in a place where you live. That doesn't take away some of the other barriers about whether the one physician that's in your community, for example, may not accept your insurance, or may already have a full patient limit and isn't accepting additional patients, and so on. So when we start looking at these additional layers of accessibility, just one, for example, is whether physicians are or a provider is accepting new patients. In a national survey, we found that only 56% were. So I started mentioning rural disparities. Driving to a provider in a rural area, rural residents have to drive 6 times longer to get to an opioid treatment program, which is what made buprenorphine such an important addition to the treatment landscape. And as I've mentioned, the increases in access to medication for opioid use disorder, particularly in the more rural areas, nurse practitioners benefited that. But how much and where and to what degree, right? So those are some of the questions that we were thinking about in the Center for Rural Health. And we said, well, let's try and do that thing that policy researchers do. Let's find some data to answer those questions. So these 3 research questions are what we explored in the second publication that was added into the chat. This is an open access journal. It was published last month. So if you click on that link, the PDF is available for you to download if you're interested. But we wanted to look at, okay, how many sites are there in Arizona and where are they located? And then when we look at rural location, using those same 4 categories that Brenna had mentioned, those RUCA codes, rural, urban, large rural, small rural, and isolated small rural, we wanted to see if the drive times differed by that degree of rurality. And then we asked a third question. If we looked at in those most rural areas, anticipating that they would be have the largest shortages or the largest need for care, unmet need for care, what if providers in those areas were to become buprenorphine prescribers, how would that change drive time? And so for this analysis, we looked at federally qualified health centers in those rural areas. So just a really quick high-level look at the methods and the way that we set up the study. So we used ArcGIS software. This is Geographic Information System software. And we had somebody smarter than me who could use that software better than I can help on this project. And she was able to data plot all of the addresses for the workforce. We downloaded a database of all of the data wave providers. So these are the buprenorphine providers, or providers who had applied to the DEA for a license to prescribe buprenorphine, what I'm referring to as data waved providers. And we identified 1,104 of those individuals in Arizona who had a practice address that was publicly identifiable through SAMHSA's website. So we downloaded all those addresses, plotted them all, identified that 941 of those individuals were at unique sites. We plotted the addresses of all the opioid treatment programs, the methadone clinics, and then we plotted all the data points of the federally qualified health centers. And in doing that, we were able to identify which of the health centers currently employ a data wave provider and which don't. And as you can see, 71 versus 78, it was about a 50-50 split. And then using that software, we were able to geomap all of these providers relative to each other. And so to calculate drive time, you need a starting point and an ending point. The starting point, because we don't have names and addresses of individuals who may need treatment, we took geographic averages. And so we identified 4,168 geographic block groups in Arizona, found the center of each of those locations, and then calculated the drive time from that geographic. So that block group center to the nearest facility. So just looking at where everybody's located on the geomap, the red circles are those 58 opioid treatment programs. The green circles are those 941 waived providers. Well, sorry, the green, blue, and the green cross, blue cross, and green circle are the 941 divided into 3 groups. The first group being those who are at an FQHC, and then the green circles are those who are not. And then the blue crosses are the FQHC clinic sites that currently do not employ a waived provider. I said that backwards, but we got there in the end. And here's how the numbers fell out from the analysis. So this first row where we're looking at all block groups in Arizona, those 4,168 block groups, the mean drive time to an opioid treatment program is 16 minutes for the state, 7 minutes to a provider working in an office-based setting who can prescribe buprenorphine. That's what we mean by OBOT, or an office-based opioid treatment. And then the potential OBOTs, those are the FQHC sites that don't yet employ, but under this hypothetical scenario where we said, hey, what could we do to further increase drive time? If we went through and knocked on all their doors and says, hey, can we help you get at least one of your prescribers waivered to be able to prescribe buprenorphine and treat patients with OUD, that further reduced it to 6 minutes across the state. But as Brenna highlighted with the behavioral health workforce, it's really at the cross section of the rurality where we start seeing really big disparities in access to care. And so for urban, large rural, small rural, and isolated, if you look from the OTP column to the OBOT column, we see significant reductions for all of them. Over 50% reduction in drive time across all rural strata. Adding the FQHCs, or expanding waivered providers to every FQHC in the state, that had a further improvement primarily for the small rural and the isolated rural areas. And if you look at the 29.7, sorry, Brenna, just to go back to what Brenna had highlighted before with Health and Human Services recommending drive times below 30 minutes. I'm not sure 29.7 minutes is going to make a big difference versus 30.1 minutes. So yeah, it is a bit of an arbitrary threshold, but to the degree that we use that as a benchmark and say, all right, well, let's try and get care to be as proximal as possible, and 30 minutes being excessively distant, it was significant or meaningful that the potential OBOTs was able to bring individuals living in all rural areas in Arizona below, potentially below a 30-minute threshold. So just to re-emphasize these 2 big key takeaways, buprenorphine is a really important treatment modality in Arizona. If methadone was our only modality or our only medication, we'd had 70, 80-minute drive times in some of our rural areas. Adding buprenorphine as another medication that's prescribed in different settings by an expanded workforce is really important, especially in the rural areas. That's what that second bullet point means. And just one last map here, and then we'll close out on this. This is kind of a way to visualize what those drive times looks like. So the map on the left that has all of the green spaces, if you lived or if you were located in one of those, anywhere in one of those green spaces, that means you would be able to access a methadone clinic or an OTP within a 30-minute drive. The blue is how that expanded under our current buprenorphine workforce, or the data wave providers. The map on the right is how that expands with, if, it's not actually the case, but under this policy hypothetical, if all of the FQHCs that currently do not have a waivered provider were to expand their workforce, the blue areas on the map on the right is the additional coverage areas of individuals within a 30-minute drive who would be able to access medication for opioid use disorder treatment. There's a lot of excellent resources and really dedicated stakeholders in Arizona that are trying to not only expand the number of providers that we have, but to provide support and assistance both to patients and providers to make treatment for opioid use disorder more accessible and more helpful. If you're a provider and you're interested in receiving one-on-one mentorship, the AZMAT Mentors program is an excellent resource for that. That's run here through the Center for Rural Health. Twice a month, ASU hosts a MAT Echo session where 30 to 50 providers get on a call for 1 hour over lunch every other week and talk about, and they review a case study and they answer specific questions around treatment. Really great resource for collegial support. Also the OR line, this is for patients and providers, family members, anybody can call this line and receive help and answer questions around what's being prescribed, how to use it. So both from a prescriber side and from a patient side. And then at the national level, PCSS has been around since the advent of the Drug and Addiction Treatment Act to provide provider resources. And Brenna, I'll leave that last point for you.
Sure, and we also wanted to highlight, then among the behavioral healthcare workforce, we saw the disparities, and that workforce might also be leveraged for co-occurring disorders. And so we wanted to be sure to highlight that there are new expanded eligibility for the state loan repayment program for a certain subset of the behavioral healthcare workforce. So we have the link to the state loan repayment program, which is managed by ADHS, and you can see the eligible behavioral healthcare providers that can receive that loan repayment program. So I think, so that's our contact information. If you have follow-up questions, if you need another reminder about where the recording is, or want to chat with us about something in these reports, feel free to contact us. And we have time for questions. So if you want to write your questions in the chat, please feel free to do so now.
So while you're thinking about what that really beautiful, wonderful question is you want to ask, doesn't have to be beautiful, a good question, any question. I could start with responding to Jen's question. She wrote in the chat and asked, how common is it, or is it allowed to provide a medication for opioid use disorder and to prescribe it in a 30-day supply? Which is a great question. Historically, for methadone, that's not been allowed. Take-home doses are really rare, and
it looks like Ben's feed has frozen. I'll text him and let him know.
Sorry about that, everyone. I wasn't sure if that was just on my end or if everyone saw that. So unfortunately, I don't have sufficient knowledge in that area to answer that question. But it looks like, are there any incentives offered to providers to be able to work in these rural areas? So there are several areas that I think provide provider assistance. And I know there's some folks on the line who would be able to provide additional information. But really, what we have in terms of structural and systematic support includes the use of the HPSA areas and the HPSA designations for eligibility for things like National Health Service Corps and the State Loan Repayment Program, right? So with a service commitment, then there's a certain, a benefit to the provider for serving in an underserved or rural area. So that's one type of program. Another program, oh, and Elisa, great. I know we have a lot of folks from the Center for Rural Health chiming in terms of the benefits to providers. So there are some, systematic benefits that, try to encourage providers to serve in these areas, but also, there's an increasing emphasis on recruiting providers from rural and underserved areas, and making sure that there's kind of this pathway connection, from a rural or underserved area to an educational program, and then back to a home community or a community where someone grew up. So that, really you're both addressing the providers in those areas and the knowledge of the community, perhaps linguistic and cultural competence as well among the providers in those areas. So there are scholarship programs at the 3 major universities for the healthcare workforce. And I think there are some folks chiming in the chat in terms of specific benefits for waived providers and how to get waived providers out into rural areas. Bridget, okay, question about why there might be a greater number of substance use disorder counselors in rural areas as compared to other disciplines. So that's something that we noticed as well. Our hypothesis, but I'd like to hear from others, has to do with the location of some of the rehabilitation and treatment centers in Arizona. But I know there's lots of folks with knowledge about that on the line. And so our hypothesis had to do with the location of those centers, which some can be located in rural, kind of the range of large rural to more isolated rural areas. But that was our initial hypothesis. Other questions or observations? It looks like Ben is connecting back to audio, so he might be able to finish what he was saying.
Yeah, and can you hear me, Bruna?
Yes.
All right, sorry about that. My computer died, so I ran across the room, grabbed my laptop. Sorry about that. With Jen's question about dosing, that's something that regulations were relaxed under COVID. And so that's an important question that we're able to actually collect data to try and answer to see if historical limitations on whether individuals can take 1 week or 2 week. So the relaxed regulations allowed methadone to be taken home up to 28 days. Buprenorphine prescriptions could always have been written up to 28 days, but oftentimes they're not, especially when patients are initially initiating treatment. Providers will give a 3-day or a 7-day script, and then as they are successful on the medication, then they can progressively get longer scripts up to where they would be coming into the clinic once a month. But that hadn't been true for methadone because of the licensure requirements around the opioid treatment programs and how they're allowed to dispense the medication. So for the last 18 months or so starting in March of 2020 under COVID, we'll be able to see how many opioid treatment programs expanded those take-home doses and what kind of effect, positive or negative, that may have had on patients' ability to receive and remain in their treatment.
And I think we had a couple questions or just observations about telehealth and the potential role of telehealth in expanding access to treatment. I know that in rural Arizona, there are some barriers in terms of infrastructure and technology to using telehealth. And I don't know, Ben, if you or if others on the line have a sense of how many folks might be using telehealth for medication-assisted treatment.
So talking to a research team that has been looking at the what type of modalities have been used, and especially under, as I'd mentioned, these relaxed COVID regulations. One of those was around telehealth, and particularly around billing parity on telemedicine, so that it's more attractive to use. The data has not been fully analyzed yet, but of the 7 or 8 different policies that were able to be relaxed, it's looking like telehealth was the one that was most often implemented. We'll have to get into the data more completely to look at what proportionally the rate of implementation and what its effect may have been on, again, patient outcomes and their ability for this to make this treatment more accessible to them.
Yeah, so a couple notes about transportation and transportation difficulties, right? So even with a reasonable drive time, that that doesn't take into account whether or not someone has a car that's always available to them, or whether or not they need to rely on friends or family for transportation, or whether or not there's any kind of network of community transportation or municipal transportation that they can access. And so that is a really important consideration that isn't fully accounted for, right, in the drive time. Whether or not the resources are available at the community level to get somewhere, or whether or not someone has resources at the individually or family level for transportation. So yep, that's definitely a key consideration.
Yeah, for the individual and for the families. And Brenna had mentioned the different types of costs that individuals experience in accessing care, a time cost, financial costs, and that comes in the transportation side, but the social costs as well. So we know, for example, if we have a single parent that's trying to access care, who can stay with their children while they're driving 20 to 40 minutes both ways, right? Or if they need to borrow the transportation, and how sustainable it is to always be needing to find a car to borrow, or if they don't have a driver's license and they're always asking a family member or friend to drive them. So lots of layers to that.
Yep. And I think we have a couple of questions in the chat. What benefits would FQHCs and the populations they serve receive if they did have a MAP provider? So, I think thinking above just, the availability of that provider, what do we see as the benefits to the community or to the health center itself for having that provider available?
So that, if I were to answer that, I think the lowest hanging fruit is the same benefits that's going to come from having integrated care available in any community, rural or urban. But to the degree that individuals can receive all of their services in the same place, makes it just so much easier to do so. And that's true for substance use disorder treatments or opioid use disorder treatments, to the degree that you don't have to go to an OTP that would be, kind of a quote unquote specialist. And the data bears that out, right? Patient experience, likelihood of receiving care, and then the quality of the outcomes all increase when pharmacy and primary and specialty care are all under the same roof.
Yeah, and I think to add on to that, and if a patient has a trusted provider or a trusted health center that they go to, having a kind of warm handoff or experience at a location, I think, can remove some of those barriers and challenges that you might see to being able to access treatment. And I see another emphasis in the chat for addressing transportation. And then, making sure that we are able in our health system in Arizona through the different payers, including access, be able to, address transportation as a barrier to health and, really cover it as people need to get to the locations where they need to receive care. So thank you, Ines, for adding that into the chat.
Yeah. And I'll also add to just double back really quick to what Brenna was saying about integrated care and MAT and FQHCs. We also see when we think about how do we train and prepare a workforce to meet the needs of the patients. So both the cultural competency is the one that we talk about most, but the question of stigma in recent years has raised, the question of professional competency as well. Like, how do we see all of our patients as deserving of care and receiving care that's free of bias, whether it's conscious or unconscious? And one of the benefits of working in a care setting where you have colleagues who have a lot of experience in behavioral health, or in working with patients who experience, who have lived experience or are substance involved, that can be really beneficial to a primary care provider, for example, who may not have had a lot of exposure to that in their medical training, in their rotations, in their residency. So to just kind of demystify and make it seem not strange or not this other type of medicine, but regular type of medicine, helping patients have a medication and troubleshoot making that medication work for them is, right in the heart of clinical care. And so medication for opioid use disorder is that. So just taking away the allure of it or the mystique of it, I think goes a long way to taking away the stigma of it.
All right, well, I think we fixed our chat to everyone feature. So if there are additional questions, how would a person seeking out MAT find a provider? That's a great question. Ben, do you want to put the links into, or do you want me to do it?
If you've got it open, I had to shift computers. Sorry,
okay, yep.
close enough for me.
Don't have it open, but I will grab it right now.
So there's a couple of resources online. SAMHSA's website has what they call a practitioner locator tool. It's not super public friendly. It's a bit more useful, I think, or at least as I've seen it used for healthcare providers to find other healthcare providers, or policy scientists, data scientists to find that information. But I believe ADHS has a treatment locator. And that's the one that I would recommend that patients and families use. If you can find the link to that, Brenna.
I'm gonna drop the.
Jessica was asking how to confirm that which FQHC locations were on the list that we had used. So we had to use separate data points and line them up using proximity of address. We had a list of providers who had publicly available practice locations, and then we had a separate list from the Arizona Department of Health Services of all of the licensed FQHC clinics in the state. Then we just put them on a map and looked at how they overlapped with each other, and then that's how we designated them as an FQHC with MAT provider. So there wasn't a single list that had that information together.
And this highlights one of the barriers to accessing care, is that it is difficult to identify locations that offer this service, providers that offer this service, and then go the second level where if you have, insurance, is it covered? How is it covered? And is the provider accepting patients? So it, even in compiling the data for the drive time research, like we ran into, some limitations and gaps in putting all that information together. So, this also highlights that there are, kind of these, there isn't one necessarily really good place for people to find out if they can really get treatment. And so, that's something that I think, could really be addressed and improve access to care. And I'm pulling up the ADHS link. If anyone else can find it faster than me, they can, please add it to the chat. You know, that's a good question, Inez. I don't know off the, I need to look into that in terms of the range of coverage under private health plans.
Yeah, sorry, just to repeat the question in case people couldn't see it. Inez asked if most private insurances pay for MAT. Oh, Lena came through for us and she corrected me. The site that I was thinking of was the governor's office site that has, you can filter by prevention, treatment, or recovery sites and then search by zip code. And so that's the link I was thinking of. Thank you, Lena. Gold star and lollipop for you.
Thank you, Lena. And yeah, Elisa made a point about behavioral health insurance parity. You know, there's been some pretty significant policy changes with regard to parity between behavioral health and medical, that kind of false dichotomy in insurance. But there are still issues. You know, I think a lot of analysis shows there isn't full parity yet in coverage between the two types of care. But with access integration and other integration efforts, you know, hopefully that dichotomy, including the coverage and payment dichotomy, reduces, and the kind of silos between where and how people receive care. All right. Well, I see that also someone else wrote in into the chat to everyone, I think, about the veterans initiative and work, and that's really great to hear. And I think we have one other message about payment issues, and it looks like reimbursement issues in Santa Cruz County. So if you, Stephanie, if you'd like to follow up with us directly and talk more about that, or if anyone wants to talk more about these gaps and ways that we might be able to investigate additional resources or address those needs, shoot us an email and we can work on it together. So thanks everyone for attending today. You should get a pop-up survey as you exit the webinar, and we really appreciate your attendance and attention.
Thank you, Ben and Brenna, for that awesome presentation and for always being available to help people with their questions. Ben and Brenna are an amazing resource. So please do, in addition to doing our survey, make sure you check out our previous webinars, and on the Center for Rural Health website, you'll be able to find contact information for everyone on staff. And a copy of the slides, absolutely, they will be available on our website and the website of the Southwest Telehealth Resource Center.